During a surgery, a patient's anterior spinal artery is damaged at T12. Which of the following best describes neurological deficits which may be found in this patient? Choice A, bilateral loss of pain and temperature sensation in the legs. Choice B, bilateral weakness and loss of pain and temperature sensation in the legs. Choice C, weakness and loss of proprioception in one leg and loss of pain and temperature sensation in the other leg. Choice D, bilateral loss of proprioception in the legs. Choice E, isolated anal sphincter dysfunction and loss of perineal sensation. I'll wait 5 seconds and answer the question. Damage to the anterior spinal artery can cause an anterior cord syndrome, where you will have damage to the corticospinal and spinal thalamic tracts. So that means motor function and pain and temperature. And this would be bilateral, so choice B, bilateral weakness and loss of pain and temperature sensation in the legs, is the correct answer. I'm keeping this question relatively straightforward because these syndromes are annoying enough to learn without a vignette that's like 5 sentences long and taking forever to just say the same thing. So let's just look at the wrong answers here and see how we can differentiate. Choice A, bilateral loss of pain and temperature sensation in the legs. So this is talking about an isolated damage to the spinal thalamic tracts. Usually on step 1, if they want to give you this, it'll be in early syringomyelia, which is basically a fluid-filled cyst forming in the central canal of the spinal cord. So since the spinal thalamic tracts are kind of close to the central canal, that kind of bulging out of the central canal by a syringomyelia can cause an isolated lesion in the spinal thalamic tract. But that's before the syringomyelia gets more severe and you'll start compressing on other tracts as well. There's some other tumors that if they grow around the same area, then yeah, you can also get an isolated spinal thalamic tract lesion. But like I said, a syringomyelia is the one they test on most often, and sometimes they may be able to ask about an association with Arnold-Chiari malformation. Otherwise, you don't see it super often. Choice C, weakness and loss of proprioception in one leg and loss of pain and temperature sensation in the other leg. This is of course referring to brown-sequard syndrome, when one lateral half of the spinal cord is completely transected. Now, this is one of those things that you would kind of consider a medical student disease, in that, yeah, you learn about it a lot because it's kind of interesting to talk about the theoretical neuroanatomy of it, and it really tests your expertise and knowledge in how these 3 tracts are moving through the spinal cord. So in this case, we have lesions to all 3 of the most important tracts, which is cortical spinal tract, spinal thalamic tract, and the dorsal columns. But because of the difference in where they decussate, it's going to look very different if you only transect one half of the spinal cord. For cortical spinal tract, because it decussates early up in the medulla before it comes down, you're going to get ipsilateral motor findings, but because it's also connecting to its lower motor neuron at the level of the lesion, what will happen is at the level of the lesion, you will have a lower motor neuron sign, but below the lesion, because you're cutting off those neurons before they reach their lower motor neuron, you're going to have upper motor neuron sign. So it'll be something like at the level of the lesion, you'll have flaccid paralysis, and then below it, it'll be spastic paralysis. The dorsal columns are more straightforward. Dorsal columns don't decussate until the medulla going up. So again, same thing. It'll be ipsilateral loss of proprioception. And then you have the spinal thalamic tract, which is the weirdest one because it enters the spinal cord and then it goes up 1 or 2 levels before it decussates in the spinal cord. So working back from that, that means at the level of the lesion and maybe 1 or 2 levels below, you will have an ipsilateral loss of pain and temperature. But because below that, the spinal thalamic tracts have already decussated, that means 1 or 2 levels below the lesion, you're going to have a contralateral loss of pain and temperature. This can get really, really confusing for a lot of people, so the easier way to remember it is to just like say, well, I'm going to have ipsilateral loss of cortical spinal tract and dorsal columns and contralateral loss of spinal thalamic tract. Even though technically you're missing a lot from that description, that's usually enough to get you questions right. I personally wouldn't be too concerned about being able to work out the super specific findings of brown-sequard syndrome. I mean, you can have it in the back of your head just in case they decide to be real assholes and ask a question like that. But like I said, brown-sequard syndrome is kind of weird because it's one of those medical student diseases where it's fun to think about the theoretical neuroanatomy, but how often is it going to actually happen in real life? Like, when do you think you're going to see a patient where they get a knife stabbed into it and it perfectly bisects their spinal cord or something? Technically, this can happen in some other things like multiple sclerosis. And in real life, brown-sequard syndrome can sort of happen in that you can have a partial trauma wound and end up getting parts of brown-sequard syndrome. And in that case, maybe a more detailed knowledge of how the tracks are running will help you with that. But like I said, it's up to you if you really want to sit down and spend the time becoming an expert at this stuff. Okay, let's just move on. Choice D, bilateral loss of proprioception in legs. An isolated dorsal column injury can result from posterior spinal artery injury, unsurprisingly named posterior cord syndrome. They probably won't test on this just because it's too easy. Choice E, isolated anal sphincter dysfunction and loss of perineal sensation. Now, obviously this refers to conus medullaris and cauda equina injury. It could refer to either one. Both of them can come with anal sphincter dysfunction and saddle anesthesia. The way to differentiate them is that conus medullaris syndrome tends to be bilateral with upper motor neuron signs, whereas cauda equina syndrome tends to be unilateral with lower motor neuron syndromes. But it is worth noting that because this lesion is above the level of the conus medullaris, then yeah, you can still get these symptoms in any of the above lesions, albeit not necessarily as severe or all at once unless it's just a complete transection of the spinal cord. So don't be surprised if you get a question that's asking about brown-sequard syndrome or anterior cord syndrome, and you also get stuff like anal sphincter dysfunction, because logically, yeah, that could happen. So bringing it back, I mean, the most important tracks for passing step 1 are definitely cortical spinal tract, spinal thalamic tract, and posterior columns, right? Here's the thing about them. If you are intimately familiar with how they run, where they decussate, you can answer any of these questions just using logic, right? The issue comes with you being able to manage your time while you're puzzling that out. So I would say you also want to have a quick reference to what central cord syndrome, anterior cord syndrome, and brown-sequard syndrome look like. And also know the quick associations with them, right? Central cord syndrome, you think syringomyelia a lot of the time. Anterior cord syndrome, you gotta be thinking anterior spinal artery lesion. And with brown-sequard syndrome, it's, you get stab wound or shot. Maybe sometimes it'll be like multiple sclerosis or something like that. And also have a quick reference of what the lesions look like. You don't want to be sitting there puzzling out every single one of them. It's a huge time drain, and unless you're just really, really good at it, I personally wouldn't recommend it. I hope this video was helpful for you. I'll see you in the next one.